Hola, buenas tardes a todos. Vamos a iniciar con el módulo de cardiopatías congénitas. Y es para mí un gusto y un honor presentarles a uno de mis amigos y colegas, el doctor Joshua Geisman. Él hizo medicina en la Universidad de Irlanda, después hizo su residencia en pediatría en Nueva York y estuvo conmigo en el fellowship en cardiología pediátrica en Sept en Toronto y es ecocardiografista fetal. Así que vamos a darle bienvenida. The stage is all yours.
Thank you very much. I don't speak any Spanish, so I hope he said nice things about me. So I understand that most people here today aren't familiar with pediatric or fetal cardiology, so I thought I'd just give a brief introduction to what it is we do in fetal cardiology. So I'll talk a little bit about the reason that we do fetal cardiology, the specific indications for a patient to have a fetal echocardiogram, what is entailed in a normal fetal echocardiogram, a discussion about counseling, which is really probably the most important part of a fetal cardiology consultation, and a brief overview of some of the fetal cardiac interventions that we do. So really the reason why we do fetal echocardiograms for early detection of congenital heart disease and congenital arrhythmias. And really what we're talking about when we talk about congenital heart disease are critical congenital heart diseases that can be very dangerous to the baby if they're not detected antenatally and if we're not prepared to manage them after birth. So things like big holes in the heart, like a ventricular septal defect or an atrial septal defect, really isn't as important to detect antenatally because those things won't necessarily be medically relevant at birth and should not be life-threatening. And knowing about these types of critical congenital heart diseases in pregnancy gives tremendous information. And one of the important things is that it gives the families information that might lead them to make specific decisions about their pregnancy. So depending on where you live, I live in Canada and abortion or termination of pregnancy is readily available. This is very important information for families to have. As I mentioned, this allows, if families do want to proceed with full active management, it allows for delivery planning. So instead of a patient who has severe congenital heart disease like hypoplastic left heart syndrome, for example, we wouldn't want that patient to deliver in a community hospital. We'd want them to deliver at a tertiary care center with the plan to start prostaglandin as soon as the baby's born, brought to the cardiac intensive care unit for further imaging and surgical planning. So that can improve drastically the mortality associated with critical congenital defects. In some cases of congenital heart anomalies, specifically arrhythmias, it gives us the opportunity to give medications to the mother with transplacental transfer to treat fetal arrhythmias. You can imagine that if a fetus is in SVT for weeks, then they can develop severe heart failure and hydrops fetalis. And finally, for very, very select indications, and this is very cutting edge and not frequently required, but there are certain fetal interventions that we can do to help prevent the progression of certain congenital heart diseases. So really what's involved in the fetal cardiology consultation is the diagnostic evaluation, which is the echocardiogram, and then counseling. And really, in my experience, having done a year of fetal cardiology in Toronto, the diagnostic evaluation certainly is very difficult, especially with very complex congenital heart diseases, more than just, the things that we hear about more frequently, like tetralogy of Fallot, hypoplastic left heart syndrome. It can get very complicated. But what requires the most skill is counseling and being able to give families all of the information that they require to make pregnancy management decisions and to be able to be an expert on each of the congenital heart diseases and to be able to answer specific questions. In terms of why we would do a fetal echo or who comes to see a fetal cardiologist for an echocardiogram, it's generally indicated when the risk of congenital heart disease exceeds 3%. So generally the baseline risk of congenital heart disease, which as many of you know is the most common congenital abnormality in the fetus, is congenital heart disease. The baseline risk being somewhere between 0.6 to 1.2%. So in Hello. Okay. In fetuses who have an increased risk for congenital heart disease, we recommend a screening detailed fetal echocardiogram. So this can be divided. So in terms of maternal factors, mothers with pre-gestational diabetes, not mothers who became diabetic when pregnant, have an increased risk of congenital heart disease, and similarly maternal medications in certain maternal conditions. There's a variable amount of increased risk depending on the specific congenital heart disease a first-degree family member has. For example, patients with a history of anomalies associated with left ventricular outflow tract obstruction, like aortic stenosis, hypoplastic left heart syndrome, can have a very significant recurrence risk up to and above 10%. And finally, factors associated with the fetus. And probably the most common indication for a fetal echo is there's a suspicion for a cardiac disease on the screening views on an obstetric scan, or the scanners were not able to adequately visualize the fetal heart, which can often signal that because they weren't able to get that views, those views were not normal. Similarly, if the obstetricians notice abnormal heart rate or rhythm, monochorionic twins is associated with an increased risk of congenital heart disease. And obviously in monochorionic diamniotic twins, there's a risk of twin-to-twin transfusion syndrome. And there are many cardiac etiologies that are associated with hydrops fetalis. In terms of what we do in a fetal echocardiogram, and this is really true for all of pediatric cardiology, is what we try to establish is sequential segmental anatomy. So in fetuses and in children with congenital heart disease, we want to see how every aspect of the circulatory system and heart are connected together. In the fetus, these views essentially are very similar to what a CT scan looks like. So really we're going up views and axial views through the chest to establish those sequential segmental anatomy. And then we use sagittal views to help to corroborate what we've seen in the axial planes. And finally, we do biometry, which helps to learn about fetal well-being and whether or not the fetus is growing. And so this is essentially what a fetal echocardiogram looks like. So we'll start with a 4-chamber view, which gives us an immense amount of information. It lets us know if there are 2 adequately sized ventricles, balanced ventricles, which side of the body the heart is on, which ventricle is which. So here you can see that they've labeled the right ventricle because it has a moderator band and because there's apical displacement of the attached atrioventricular valve, which is a tricuspid valve. But that's not always true in congenital heart anomalies. You can have a morphologic right ventricle on the left side, which we'll see, and a morphic left ventricle on the right side. Here we can see that there's balanced atria. We can see here the flap of the foramen ovale, which of course is patent in fetal life, and the normal direction of foraminal flow is from the from the right ventricle to the left ventricle, and the right atrium to the left atrium in the fetus. We can see pulmonary veins, and so this just one screening view can give us a lot of information about the fetus. As we move cephalads, or towards the head, we see the left ventricular outflow tract. And as we move more superiorly, we see the right ventricular outflow tract. And finally, at the top here, we have what we call a 3-vessel view. And this is essentially like a CT of an axial plane of the aorta, pulmonary arteries, and superior vena cava. And this is a very useful screening view because it can accurately screen for congenital heart disease. So what we want to see is that the pulmonary artery is the most anterior vessel and should be the biggest size because it's in the fetal life receiving 60% of the combined cardiac output. And then we should have an aorta, which is posterior and leftward, posterior and rightward. and finally a superior vena cava. And they should all be in that exact straight line. So they should have that correct size arrangement, and they should have that correct arrangement in space. But if we have, for example, an aorta that's anterior and right, that might suggest that there's an abnormal ventricular arterial connection or transposition of the great arteries. If, for example, the pulmonary artery, if they're aligned properly, but the pulmonary artery looks small, that might indicate that there's a lesion that restricts the amount of blood flow to the pulmonary artery, like tetralogy of Fallot, for example. And then finally, we can turn the probe 90 degrees and get very nice sagittal views. And these can help us to look at the aortic arch, which we can see very nicely, and evaluate for things like coarctation of the aorta. A nice bicaval view to help us to make sure that the inferior vena cava is intact and connected to the right atrium. Some congenital heart diseases have an interruption of the inferior vena cava. And finally, down here, we can see this is the ductal arch. So it's more less of a candy cane shape and more straight and hockey stick shaped. And we can see how it arises from the right ventricle when we compare to the aortic arch view. I just have a few videos here, and really for people who haven't spent a lot of time looking at fetal echocardiograms, the easiest is to look at the 4-chamber views. These images aren't playing. Can we make them play? Are you able to click on them from there? So on the left side of the screen here is a normal 4-chamber view. So this is a patient we can see with balanced ventricles, a good sized right ventricle here. Beautiful. And we can see that this right ventricle has a moderator band, so we know it's a right ventricle. And then here, to contrast, we only have really one pumping chamber here. It's trabeculated throughout, so we know this is a right ventricle. So what we're missing is a left ventricle. And this is essentially the findings we see in one of the most severe forms of congenital heart disease, which is hypoplastic left heart syndrome. We can see a little tiny left atrium here, but it's not emptying into a ventricle. So this is a specific subtype of hypoplastic left heart syndrome with mitral and aortic atresia. Oh, that's how it works. I have to press the button. Okay, and now into the most important part of the fetal consultation, which is counseling. So the first thing we do with a family is we sit them down. We have to allow ample time. We have very busy clinics, but we have to allow at least an hour to talk to these families, especially if there's a very severe diagnosis. This is obviously not just the patient, but this is one of many patients for us, but this is the most important and probably the worst day of this family's life. So we explain the diagnosis with the aid of diagrams, and we explain why the diagnosis is important. So in diseases that have inadequate pulmonary blood flow, it'll be that the patient is going to come out blue with low oxygen saturations. If it's a disease with obstruction to systemic blood flow, these patients are going to come out, and as the duct closes, the ductus arteriosus will be extremely unwell. And then we want to explain to the family exactly what's going to happen after birth, where they're going to go, how long they're going to be in the hospital, when they're going to have the surgery, and then finally explain what the cardiac surgery will entail. And we use that also with the aid of diagrams. And this is an extremely difficult skill because you're explaining generally to people who have very little medical knowledge, extremely complex congenital heart disease. So you have to balance keeping things simple enough that the families will understand, but complex enough that they'll understand the significance. Then we'll explain the implications for the pregnancy. For the most part, babies do very well during pregnancy because they're still connected to a placenta. So as long as they don't have diseases that feature severe right ventricular dysfunction or severe tricuspid regurgitation, the babies typically don't develop hydrops as a result of congenital heart disease. They're still connected to a placenta, which is essentially VA ECMO. So we explain to families that the baby's essentially in an intensive care unit while they're in the abdomen. But very importantly, we discuss pregnancy management options, including the option for termination of pregnancy. Usually we will present, and obviously this is going to depend on where you are, 3 options, and one is full active management. We'll take the baby and offer all surgeries possible. We'll offer an interruption of pregnancy, certainly, which is a termination or abortion. And finally, for select types of congenital heart disease, we can offer compassionate care for families who do not feel comfortable proceeding with termination of pregnancy, but don't want to put their baby through usually multiple operations, lots of time in hospital, and very difficult life, where we allow the baby to be born and then we support it with palliative measures, keep it comfortable as it naturally passes. We discussed genetic testing, which can affect both the way the family looks at the prognosis for the baby. So some families will say, we can handle the congenital heart disease, but if this is also associated with Down syndrome or DeGeorge syndrome, Kabuki syndrome, that really is a major change for them. And similarly for us, patients who have underlying genetic syndromes are going to have worse outcomes with respect to their cardiac repairs. In terms of continuing pregnancy, we refer the patients to a high-risk pregnancy department with maternal fetal medicine doctors who can evaluate the fetus for other congenital anomalies. And we usually schedule a follow-up fetal echocardiogram at about 28 weeks just to assess fetal well-being and to see if there's been any progression of disease. And then we have to talk about, what happens after the baby leaves the hospital. So most congenital heart disease babies will be in the hospital for a month or so, and then they go home. But what's that? The baby? Is this going to be a one and done surgery where we just need to follow them periodically? Or are we going to expect multiple surgeries, multiple revisions, lots of time in hospital? And we have to discuss specifically the mortality, which is very variable along congenital heart diseases. And specifically, we have to talk about the long-term morbidities. So a lot of the types of surgeries that we can do in pediatric cardiology, kids can get through okay. Things like hypoplastic left heart syndrome, the palliation, the children get a Fontan operation, and they're able to walk, talk, and play and go to school. But as we'll see from my colleague's talk, morbidities start to accrue in adulthood. So as a pediatric cardiologist, everything looks okay because, we got the kids out of the hospital. But a lot of the repairs we do are associated with long-term morbidities. And finally, we recommend fetal echo, and we can actually do first trimester ultrasounds as early as 12 weeks for subsequent pregnancies. Just briefly talking about medical management, this is how we assess for arrhythmia in the fetus because we can't put ECG leads on a fetus. Very challenging. So we put an M mode through the atria and the ventricles, and that allows us to electromechanically detect atrial and ventricular events. On the left side of the screen, we have a patient with reentrant SVT, and we can treat transplacentally with medications like digoxin, sotalol, and flecainide. Beta blockers don't cross the placenta. In the second image here, this is fetal atrial flutter. So you can see these humps in the near field are the ventricular events, and in the far field are the atrial events. So you can see that the atrial events are double the ventricular events. So this is going at a rate of 400, and the atria or the ventricles are going at a rate of 200. So this is atrial flutter. And finally, we have a congenital complete heart block, which is most frequently associated with autoimmune diseases like lupus. And we can slow or the progression of these diseases with things like steroids and intravenous immunoglobulin. And finally, just a very short mentioning, this is something that deserves 2 hours of talk about, is fetal cardiac interventions, which we do quite rarely. In Toronto, which was where I trained, which is a quaternary care center, we do 1 or 2 a year. The most common things we do are for aortic stenosis, so patients with critical aortic stenosis. We can take the patients to do a procedure where the obstetrician will place a trocar through the maternal abdomen and then through the baby into the fetal heart. And then an interventional cardiologist can then put a balloon through there to balloon the valve. And the reason that we do that is that aortic stenosis is associated with progression to hypoplastic left heart syndrome, which is a very different disease than just having aortic stenosis. Because in the fetus, the growth of the left ventricle is determined by flow into the left ventricle. And if you have aortic stenosis, an increase in the filling pressures of the left ventricle, blood is going to stop flowing into it, and it's going to stop growing, and you're going to end up with a hypoplastic left heart. So for select fetuses, we can do a balloon valvuloplasty to help to prevent the progression to hypoplastic left heart syndrome. I accidentally switched these pictures, but in patients with hypoplastic left heart syndrome, we can do a similar procedure where we can put a balloon across the atrial septum. And this is for patients who have a subtype of hypoplastic left heart syndrome where they don't have a adequately sized foramen-ovale or atrial communication. And then all of the pulmonary venous return into the left atrium has nowhere to go. And you get severe lung disease, which pretty much makes palliation for hypoplastic left heart syndrome impossible. And the similar idea for pulmonary stenosis here, where we can balloon the pulmonary valve to prevent progression to hypoplastic right heart syndrome. So fetal echo can accurately diagnose critical congenital heart diseases. Early detection allows for pregnancy management options, in utero interventions, and delivery planning. And counseling, as I said, is as important of a skill as accurate diagnosis. Thank you. We're going to go straight into the next one. There it is. Okay, so we're going to talk a little bit about how we go about repairing congenital heart disease. So we're going to assume all of those patients with fetal congenital heart disease were brought to birth, and then we're going to talk about how do we go about repairing congenital heart disease. So very broadly, we can describe congenital heart diseases as holes, so things like septal defects, patent ductus arteriosus, obstructions like outflow tract obstructions, aortic stenosis, pulmonary stenosis, subaortic stenosis, coarctations, abnormal connections like transposition of the great arteries, interrupted IVC, for example, where the inferior vena cava doesn't return normally to the right atrium, and anomalous pulmonary veins, and then atresias, where things that are supposed to be there don't develop. So ultimately, the goal of our surgeries are to end up with unobstructed outflow tracts, with intact septae, so intact walls between the atria and the ventricle, at low pulmonary artery pressures, because the surgery isn't successful if it leaves the PAs at high pressure, and to achieve ventricular arterial concordance, which means a left ventricle going to an aorta and a right ventricle going to a pulmonary artery, and of course with the caveat that this isn't always possible. So let's just start with the most simple congenital heart disease, which are holes and blocks. On the left side of the screen, we have a large atrial septal defect. In the middle, a ventricular septal defect. And on the right, an echo-cardiogram. Many of you are familiar with aortic stenosis. And this isn't very complicated. We can address these either in the catheter laboratory or in surgically, if it's not feasible in the cath lab, with ambulatory devices or devices that plug this hole, and balloons or valvotomy to address an obstruction. Not too complicated, but we can certainly add complexity. So the most simple form of complex congenital heart disease is tetralogy of Fallot, which is essentially a hole and an obstruction. So your hole is a ventricular septal defect, and your obstruction is pulmonary stenosis, which results because the outlet septum, which separates the pulmonary artery and the aorta, is deviated anteriorly and creates subaortic obstruction. And so it's quite simple to repair. It sounds simple to me because I don't know how to do an operation, but I'm sure to the surgeons it's more complicated. The way we do it now is through an atriotomy. The surgeons will go in through the right atrium to avoid cutting into the ventricle for the sake of preventing arrhythmias and heart block. Put a VSD patch over the ventricular septal defect, and then there's two flavors of tetralogy of Fallot repair. There's a valve sparing tetralogy of Fallot repair where they simply try to repair the valve. But in cases where the valve is too dysplastic or the outflow tract is too narrow, they'll do what's pictured here, which is called a transannular patch to augment the outflow. And transannular patch repairs are associated with essentially free pulmonary regurgitation, and the patients will ultimately need a pulmonary valve later in life, which we'll learn about in the next presentation, I expect. In terms of patients with abnormal connections, the most frequently thing you'd think about as someone who's not a pediatric cardiologist is probably detransposition of the great arteries. This is the classic blue baby syndrome. And these are cases where the right ventricle is attached directly to the aorta and the left ventricle is attached to the pulmonary artery. And you have two separate parallel circulations instead of an in-series circulation. And the oxygenated or deoxygenated blood can't get to the lungs. It stays in the body, and the oxygenated blood is just recycled back to the aorta. Now, the original way that this was repaired, and this was a surgery that was developed actually in Toronto a very long time ago, was something called an atrial switch operation. So they devised a way to get the blue blood all the way to the left side of the heart so that it could pump to the pulmonary artery. And then it would become back oxygenated and then go back over the baffle into the right ventricle and pump into the aorta, which is great because then you have all oxygenated blood. However, we learned over time that this is not the ideal repair. There's a lot of cutting into the atrium, which leads to atrial arrhythmias, atrial fibrillation, atrial flutter. There's a lot of hardware in the heart, which are very easy to become obstructed. And then most concerning is that now we have a morphologic right ventricle pumping the red blood into the aorta. And the right ventricle is not designed to pump to a systemic circulation, and over time it will fail. And ultimately, these patients frequently require heart transplant. What we do contemporarily is arterial switch operation, which was developed in Brazil by a surgeon named Dr. Jatin. And here what we do is we transect the aorta above the valve, we transect the pulmonary artery above the valve, and we simply switch them. So the pulmonary arteries are brought very forward in a maneuver called the Lecomte maneuver, and the aorta is pushed backward over the left ventricle. And then the coronary arteries are taken off on little buttons and reattached into the neo-aortic valve. And this has excellent long-term outcomes. As a surgery we do several times a month at sick kids, and the children typically do very well. But certainly we can always add complexity. So we can have transposition, which we see here again, the right ventricle pumping to the aorta. But we add in a hole, a ventricular septal defect, and a block. So we have pulmonary stenosis. So now an arterial switch operation isn't possible because there's a big size discrepancy between the vessels. You can't just cut them and switch them because you won't be able to fit one into the other. One looks more like a pipe cleaner and one looks more like a pipe. And so we have several possibilities about how we can fix this. The first is something called a Rastelli operation. This is really the most simple and the most ideal if the patient is suitable for it. And there's a nice straight line between the ventricular septal defect and the aorta, is we simply close the ventricular septal defect such that the blood will go over the ventricular septal defect into the aorta. The pulmonary artery is transected from the left ventricle, and then a Gore-Tex tube is put in to connect the right ventricle to the pulmonary artery. So in this case, you have a left ventricle pumping red blood through the aorta, which is really the ideal situation. In patients who is not suitable for a Rastelli operation, where the left ventricle isn't a straight shot to the aorta, and we can't repair it with a Rastelli, we do what's called either a Nikkei-Do or a Rev operation, which is similar, where again we transect the aorta off of the right ventricle, and then we cut straight down into the interventricular septum to make room for that aorta and push the aorta back. That's called a posterior aortic root translocation. And then we either put a transannular patch, like we talked about with tetralogy of Fallot, over to augment the outflow from the right ventricle to the pulmonary arteries. And that's essentially what happens in we'll call the Rev operation. And then in a Nikkei-Do operation, that would be a conduit similar to what we saw in the Rastelli. Now, this is a very interesting disease, LTGA, or congenitally corrected transposition of the great arteries. And what we have in this case is patients who have the blue blood coming into the right atrium, but it empties into a morphologic left ventricle. And that left ventricle then pumps what you would expect to a pulmonary artery. And then red blood returns to the left heart and goes to a morphologic right ventricle, which pumps to the aorta. So you might ask, well, what's the big deal? The patient is going to be fully saturated. They're going to look fine. But it's really the same problem that we had earlier when we talked about the mustard operation or the atrial switch operation, where you now have right ventricle pumping into a systemic circulation, and that right ventricle is eventually going to fail. Did I reverb myself? Okay, I scared myself. And this is what we have here is a echo description of that. So we can see here that this looks very abnormal for a transthoracic echo in a four-chamber view. You can see that this valve is actually, so this is the left atrium here, but this valve here is a tricuspid valve. And we know it's a tricuspid valve because it's more displaced towards the apex. And this is a morphologic right ventricle on the left side, which we can see is very trabeculated throughout. We can't really see a moderator band here, but this might be part of the moderator band. Versus the other side, the left ventricle has a very smooth septal surface with a more basal atrioventricular valve, which is a mitral valve. So we can see that the ventricles are on the wrong side and the atrioventricular valves are on the wrong side. And we repair this with a very fancy operation called the double switch operation, which is essentially a combination of the two types of repair for anomalous, transposition that I talked about earlier. So it entails an atrial switch operation where we bring the blue blood all the way over to the left side. But then if we just left it at that, then we'd have the problem of the blue blood being pumped to the aorta. So in addition, we also have to do an arterial switch operation. Where the great arteries are cut and transposed. And so now we have, again, a situation where red blood is coming back into the left atrium, over the baffles, into the right-sided left ventricle, which can then is more adept to pump to a systemic circulation. And the last thing I want to talk about is hypoplastic left heart syndrome and how we can approach this. So this is a patient with classic hypoplastic left heart syndrome. There's no mitral valve, there's no aortic valve. All of the systemic and pulmonary venous return are mixing around in this right ventricle, so the patients are going to be cyanosed. And patients are going to have very low systemic perfusion when they come out. And the reason for this is, one, their aorta is extremely small, and they typically have a coarctation. And the second is that right ventricle is now pumping into the main pulmonary artery, and some of the flow will go towards the body, but most of it will go towards the lungs because we know that the lungs are at a much lower pressure than the body. So the right ventricle is now splitting its cardiac output between the lungs and the body. And because the PA pressure is typically low, or pulmonary vascular resistance is more accurate to say, the body doesn't get a lot of flow. And so the more immediate problem we have is that we need to improve the systemic perfusion by repairing the aortic arch and limiting the pulmonary blood flow. And that's something called a Norwood operation, which I'll show you on the next slide. And the long-term goal is to have a normal oxygen saturation and to have all of the blood in this right ventricle being devoted to systemic output. So you don't want to be dividing your cardiac output into the lungs and into the body. And that's something called the Fontan operation. So the initial operation that we typically do is something called a Norwood-Sano operation. And what we do is we transect the lung artery, the main pulmonary artery, off of the heart, and we attach it side by side with the teeny tiny aorta to augment the ascending aorta. And that's something called a Damas-K-Stanzel anastomosis. Secondly, now we don't have any way to get blood flow to the lungs, and this is one of the shunts we use, and this is the one we use at our center. It's called a Sano shunt after the surgeon who described it. And you'll see that this is a much more narrow tube to get blood flow to the lungs because we purposely want to limit the amount of blood flow going to the lungs. As I said on the previous slide, the more blood flow that goes to the lungs, the less blood flow that goes to the body. And the normal saturation after the Norwood operation is 75 to 90%. And the babies will live with that situation until their next operation when they're 4 to 6 months old. And this is actually the ideal saturation. If a baby has a higher saturation than 90%, it means they're getting too much blood flow to their lungs, not enough blood flow to their body, and they're at very high risk of things that result from poor systemic blood flow, like strokes, gut malperfusion, gut necrosis. So if you see a baby who's just had their Norwood-Sano operation and have a saturation of 95%, that's not a good thing. That's a bad thing. At 4 to 6 months of age, the patients will have the second stage operation, which is called a bidirectional cavopulmonary connection, or BCPC, also named after a surgeon named Glenn. And that's where the superior vena cava is now attached directly to the lung artery. So instead of having a right ventricle or any ventricle pump blood to the arteries, to the pulmonary arteries, blood is flowing passively into the pulmonary arteries through the superior vena cava. And now we've accomplished our first goal, which is that now all of the blood which comes back to the right ventricle from the lungs and from the body is mixed, so it's cyanosed, but now it's all going to the body. We don't have to worry about balancing the circulation. So now our main problem is that we're still blue. And so this operation is done at 4 to 6 months of age. And then actually at 3 years of age, we do the Fontan operation, which is the final stage of the 3-stage palliation for hypoplastic left heart syndrome. And really the reason why we take a few years before we do this is to allow the circulation to adapt. And so you can't just pull the inferior vena cava all the way up to the lungs. So we put in a tunnel or a tube. The types of Fontan we do in our center are extracardiac, so they run alongside, and brings the inferior caval blood flow to the lungs. So now all of the blue blood is coming to the lungs. All of the blood then returning from the lungs to the heart is red, and all of the work that the left or the right ventricle has to do is pump all of this red blood to the body. It's still certainly not a normal circulation, and as we'll learn that this circulation is fraught with complications because now you have very high central venous pressures because you have a lung pressure essentially serving as your central venous pressure, and this leads to a number of complications, which I'm sure we'll hear about, but can allow at least children through childhood to have relatively normal oxygen saturations. And that's just the tip of the iceberg. That was all kind of bread and butter pediatric cardiology. It gets much more complicated. And I'm not going to tell you how this one is repaired, but this is a diagram of a patient with right atrial isomerism, which is a form of heterotaxy syndrome, a full atrioventricular canal defect, which is right dominant, so there's a small left ventricle, pulmonary atresia, so there's no outlet from the right ventricle, total anomalous pulmonary venous return, so the lung the venous return from the lungs goes up towards the superior vena cava, and bilateral superior vena cava with the left one going to the roof of the common atrium here. So you can think to yourself about how you might approach this heart, but this is really the crux of what pediatric cardiology is all about. So you can become a pediatric cardiologist or heart surgeon to find out the answer to that question. Thank you very much, and come visit me in Toronto.
Thank you, Josh. That was amazing. Todavía recuerdo con dolor mis años de fellowship. Hacerle un eco, un double switch es verdaderamente doloroso. Ahora con mucho gusto les presento al doctor John Araujo. Él es cardiólogo, ecocardiografista en cardiopatías congénitas pediátricas y del adulto. Hizo su fellowship en el Hospital de Valdebrón en Barcelona, España. Es el co-chair en Consejo Interamericano de Cardiopatía Congénita del Adulto y es presidente del capítulo en Cardiopatías Congénitas del Adulto y de la Sociedad Colombiana de Cardiología en Colombia.
Gracias. Bueno, muchas gracias por la introducción. Muchas gracias nuevamente. Muy contento de estar aquí en este evento. Después de que han platicado mucho sobre cardiopatías congénitas, viene este punto: ¿qué hacer cuando ya empiezan la etapa adulta, cierto? Y es que el proceso de la cardiopatía congénita es de toda la vida, como se lo ha dicho antes. Realmente los defectos congénitos no se curan, sino se reparan. Y esta es la línea del tiempo que un enfermo con defecto congénito haría a través de su vida. Nacer con una cardiopatía congénita es una condición donde la cardiología pediátrica hace un buen cuidado, hace un diagnóstico, una reparación quirúrgica o hemodinámica. Viene una etapa crítica que es la adolescencia, donde muchos de estos pacientes pediátricos pierden el seguimiento y dejan de asistir a los controles de cardiología. Pero aquellos que lo logran y sobreviven, pues pasan al campo del adulto con cardiopatía congénita, que finalmente envejecerá y pasará ya a la cardiología geriátrica. Entonces, la cardiopatía congénita, una vez tratada, debe ser transferida al servicio de cardiopatías congénitas del adulto. Pero vean ustedes que una vez se nace con un defecto congénito, tiene residuos y secuelas de cardiopatías congénitas que en la edad pediátrica están presentes de acuerdo a la complejidad del defecto, pero que además en la vida adulta se le añaden las enfermedades propias del adulto. Así que un enfermo se hace más enfermo y empezamos ya a hablar el riesgo de la muerte súbita de acuerdo a la severidad de la cardiopatía, donde siempre tenemos que estar actuando en prevención, la paliación y los cuidados al final de la vida. Este sería, digamos, un esquema general de lo que harían los enfermos. Ostras, ¿qué pasó aquí? Lo que harían los enfermos en esto. Y entonces vienen los conceptos de transición y transferencia. La transición es el pasaje de una fase de la vida a otra, de una condición física o de un rol social a otro. Eso en términos generales. La transferencia es mover, es transferir de un servicio a otro, es el acto en sí. La transición es un periodo de educación, de formación para una transferencia que se sucede ya cuando termina el ámbito pediátrico y se pasa a ser adulto joven. Esto para cualquier condición social o cualquier enfermedad crónica. ¿Cuál es el objetivo de transferirlo? No solo porque se volvió grande ya, nos quitamos la responsabilidad, sino que estamos hablando de un individuo, de un ser humano que nació con una cardiopatía congénita. Lo rehabilitamos, lo operamos. Pero ¿cuál es el objetivo? Que este individuo sea autosostenible y autosuficiente para la sociedad. Reparar cardiopatías complejas no es para que estemos haciéndoles visitas y medicando y ecos y cateterismo, sino que este individuo pueda tener un rol en la sociedad. En el caso que pueda formar una familia, que pueda elegir un trabajo y que pueda ser autosuficiente y productivo para una sociedad. Entonces, el primer punto, ¿por qué importa la transición en las cardiopatías congénitas? Vean ustedes, hoy de cada 10 enfermos adultos con cardiopatías congénitas, uno tiene 60 años o más. Al menos esto en la comunidad europea. Por eso ustedes ven los textos clásicos de los europeos, las famosas Grown Up Congenital Heart Disease. Eso lo creó James Somerville en la década de los 90, refiriéndose a la población crecida con defectos congénitos que ya no eran niños. Pero resulta que en Europa ya están tan crecidos que ahora ya están envejecidos. Entonces, el término de grown up se ha eliminado de la literatura médica. Realmente ya todos son adult congenital. ¿Y qué conocemos? 40% de los enfermos con defectos congénitos complejos hoy tienen 60 años o más. 75% de defectos de moderada complejidad y los defectos simples siempre de buen pronóstico. Eso quiere decir que todo lo que estuvieron platicando ahora del Fontan, del single ventricle, del ventrículo isquioplásico, pues vamos a tener estas cifras estadísticas como lo está mostrando en Europa. En Latinoamérica, esto es lo que nosotros hemos dado un seguimiento a través del tiempo, empezando en la década de los 2000. Hablábamos una prevalencia de 500,000 de adult congenital, pero que al 2020 ya estaban llegando casi al 1.8 millones, distribuidos en todos los países de la región. Por cada 3,000, o mejor dicho, por cada 1,000 personas, 6 tienen cardiopatías congénitas. Por cada 1,000 adultos, 6 tienen cardiopatía congénita. Y entonces, todo lo que están haciendo en cardiología pediátrica está muy bien. Los niños se rehabilitan, se operan, se siguen y se crecen. No solo porque crecen en adultos, sino porque también crecen en número. Pero viene un limbo donde ya se convierte adulto y no es ni de allá ni de acá. Entonces, esta gráfica esquematiza el éxito que se está logrando en cardiología pediátrica, pero que estos individuos no pueden caer al vacío y ser perdidos del seguimiento. Y vean ustedes, las 10 primeras causas de descompensación de un adulto con cardiopatía congénita. Un 90% de estos individuos va a tener arritmias. Es el síntoma más prevalente y pueden ser arritmias graves como el flutter, la fibrilación, que dependiendo de una cardiopatía congénita, una fibrilación o flutter dicen, bueno, eso lo pone algo inestable, lo pone mareadito, pero si hablamos de un paciente que fue operado con un Senin o con un Muster, llegar a un flutter o un FA es casi sinónimo de muerte súbita. De hecho, estos adultos mueren por una FA o por un flutter cuando están en un Muster o en un Senin. Entonces, no es tan sencilla la arritmia dependiendo de la complejidad. La insuficiencia cardíaca ya es una pandemia, sobre todo en los países europeos, porque muchos adultos llegan en estados avanzados de cardiopatía congénita y es un grave problema. Y viene la endocarditis, los eventos tromboembólicos, los sangrados, la hipertensión pulmonar, hasta la muerte súbita. Tarde o que temprano, un adulto con cardiopatía congénita no seguido en el tiempo llega a un servicio de emergencias por alguna de estas complicaciones. Y los que hacen cardiología del adulto lo han visto. Así que, ¿cuál sería la situación en el mundo de estos pacientes que ya están en edad adulta? Se acepta globalmente que la pérdida en el seguimiento es de un 26% en el mundo entero. Cuando discriminamos Norteamérica 34, Canadá 25 y la Unión Europea solo un 6.5%. Vean ustedes que cuando no se hace intervención en hablar de la transición y transferencia, la pérdida es muy alta, hasta un 36%, pero cuando se hace intervención reduce notoriamente. ¿Y qué es lo que sucede en nuestra región Latinoamérica? A través de trabajos locales de investigación, nosotros vemos que en la cardiopatía congénita del adulto, solo un 30 a 40% de los pacientes que se están visitando en la cardiopatía congénita del adulto provienen de la cardiología pediátrica. 30 a 40%. Es muy bajo. 30% de los adultos que los vemos son cardiopatías congénitas diagnosticadas de novo, que nunca fueron tratadas ni manejadas en la infancia. Si bien la mayoría son simples, pero también nos encontramos sorpresas con cardiopatías complejas como tetralogía de Fallot, ventrículo único no reparado, que llegan a la edad adulta con sobrevida natural. Y otro 30% son cardiopatías complejas con procedimientos intermedios o paliativos que no se completaron. En otras palabras, 60% de los pacientes llegan no de la cardiología pediátrica, sino pacientes que fueron perdidos en el seguimiento. Así que nosotros en Latinoamérica realmente nos preparamos para ver enfermos, más enfermos de las condiciones habituales que tiene una cardiopatía congénita. Y esto se debe a que una vez los niños son tratados en los servicios de cardiología pediátrica, no son educados para el resto de la vida. Y estos son los famosos gaps que tienen las personas en cardiopatías congénitas. Y vean ustedes este estudio realizado en Europa con 296 pacientes. Jóvenes adultos se les preguntó, ¿cuál es tu expectativa de vida? Entonces, ojo, aquí entrevistaron pacientes sanos y pacientes con cardiopatía congénita. Y la mayoría de todos los pacientes con cardiopatía congénita decían que tenían una expectativa de 75 años, más o menos 4 años diferentes al de la media. Es decir, se creían tan bien que decían que ya iba a vivir 75 años. Pero es cierto que nadie conoce un Fontán que tenga 75 años. Esos individuos a los 30, 40 años se trasplantan de corazón. No hay un Fontán de 75 años vivo. Así que estos gaps es porque no están educados y los jóvenes adultos no comprenden la severidad de su cardiopatía congénita. Y vean ustedes, en verde, cardiopatías simples, en azul, cardiopatías complejas y en rojo, cardiopatías moderadas. Todos creían que iban a tener una expectativa de vida tan alta como la población general. Y esto realmente hay que educar a los jóvenes. Porque a los jóvenes le pasa lo que le pasó a Ícaro, como dice la leyenda, ¿no? A Ícaro le fabricaron unas alas que estaban pegadas con cera. Entonces le dijeron que pueda volar, pero que no se acerque tanto al sol. Ícaro hizo caso omiso y el sol derritió sus alas y finalmente Ícaro cayó desplumado y recayó. Entonces esto es lo que pasa a los adultos congénitos con cardiopatías congénitas, que se sienten tan bien que abandonan el seguimiento, abandonan los tratamientos, pero que 5 o 10 años después recaen por una grave complicación. Y esto está constatado, de hecho, en las guías de Adult Congénito de 2018 del American College y de la AHA, donde realmente conocemos que estos defectos congénitos no están curados, están reparados y tienen recaídas. ¿Y por qué se sucede? La maduración cerebral de los individuos es distinta. Ya sabemos que es de la parte inferior a superior. Por lo tanto, las áreas cerebrales que controlan las emociones se desarrollan más tardías. Hay un imbalance entre el sistema límbico, es decir, la parte sensorial motora se desarrolla más rápido, que son las cortezas posteriores del lóbulo occipital y lóbulos parietales, mientras que la región frontal, la que hace la conciencia, el pensamiento abstracto, se desarrolla más tardía. Y es por eso que los jóvenes toman conductas riesgosas como los deportes extremos, como el jumping jump, como los cross y todo demás, que al tener una cardiopatía congénita, pues puede desencadenar graves consecuencias. Y esto es cuando se hace intervención versus no intervención. En Norteamérica, vean ustedes aquí, este cuadrito no sale bien, pero les preguntaron a adultos congénitos con cardiopatías de baja complejidad, de mediana y de alta complejidad. ¿Qué sabían sobre su condición? La mayoría decían que ya no requerían tratamiento, que ya no necesitaban más controles y que ya se sentirían curados. Y vean ustedes que incluso las cardiopatías congénitas, hasta un 30-40% de estos pacientes así lo cree. Cuando se hace intervención, aquí tenemos dos grupos, un grupo en el cual se hizo educación y un grupo en el cual no se hizo educación. Y los conocimientos sobre sus cardiopatías congénitas mejoran sustancialmente con un 60 a un 90%. Por lo tanto, el objetivo de esta conferencia es qué es transición y cuándo se debe hacer. Y comienza tan temprano que esto realmente es labor del cardiólogo pediatra. El cardiólogo pediatra está siguiendo al chaval con una cardiopatía congénita, pero ya alrededor de los 12 años, ese individuo, si no es sindromático, ya es consciente que tiene una enfermedad y que está yendo a visitas y controles y visitas y controles. Por lo tanto, a los 12 años es una etapa donde el individuo ya tiene conciencia y se le llama la pretransición. La transición comienza alrededor de los 14 años y se continúa alrededor de toda la adolescencia y un poco más allá de la vida adulta joven. La transición es educación que se le debe brindar a los cuidadores, mamá, papá, hermanos y al propio paciente. Y finalmente viene la etapa de transferencia que está entre los 16 y 18 años. Porque a los 14 años es una etapa importante. A los 14 años el individuo puede estructurársele una entrevista que se resume con estas siglas HATS. Y esta está en el manuscrito que se ha publicado hace unos años sobre transición y transferencia, donde home, se me fue para atrás, home, la casa, ¿sí? La educación, las actividades, la dieta y las drogas. A través de una entrevista, que no quiere decir que sea literalmente estricta esta que plantea las guías, se le preguntan cosas tan importantes como el consumo de alcohol, los hábitos alimenticios, el acceder con drogas o no, sobre las conductas depresivas, actividades, hobbies, educación, metas profesionales, etcétera. Y se va tamizando al individuo para tener una puntuación. ¿Cuándo se debe hacer esto? Entonces, esto fue hace unos años atrás. 11 sociedades científicas nos unimos para trabajar en cabeza del profesor Philip Mons de Bélgica. La Sociedad Interamericana también participó. Hicimos este consenso que ya se publicaba en el 2020, 2021, que usted lo puede encontrar en internet, donde que la transición en Europa, en el Asia y en Oceanía es muy diferente, porque estos países tienen ya buenos niveles de atención en salud, ¿cierto? No es lo mismo que se sucede en África o lo mismo que sucede en Sudamérica. Así que el punto de vista de cada sociedad, incluyendo la Sociedad Interamericana, hicimos este consenso en conjunto, donde vimos todos los puntos de vista de cada país y están las pautas para desarrollar un programa de transición y transferencia. Las justificaciones: más del 90% de los niños con defecto congénito viven, la pérdida global del 26% y que las medidas de intervención inician con la pretransición, la transición y la etapa posttransición. Volvemos a resumir: a los 12 años el individuo es consciente, a los 14 años podemos hacer las entrevistas iniciales y un proceso de educación que incluso no termina a los 18 años, sino que se extiende un poco más hasta el adulto joven de 20 a 24 años. Consiste en platicar, explicar la enfermedad del individuo como enfermo crónico, dar consejos sobre su autocuidado, gestión, integrarlo a una sociedad para que sea autosuficiente y sea una persona productiva. Y entonces esto es lo que proponen las guías. Ustedes están enseñados que tienen un paciente pediátrico, lo llevan, y el chaval cumplió 18 años y dicen, este chavo ya no es para mí, lo pasan al cardiólogo del adulto. En el mejor de los casos, un cardiólogo interesado, si no, le pasó para el que le caiga. Ya hoy en día existimos cardiólogos especialistas en adult congénito, entonces tomamos estos pacientes y los seguimos. Pero vean ustedes aquí que el individuo llegó a los 18 años, hizo una corta presentación, te voy a pasar este paciente y lo pasó. Este se llama el modelo de salto, donde el individuo simplemente pasa de un servicio a otro. El modelo introductorio, donde el paciente está llegando a la edad adulta, hace unas visitas como compartidas entre cardiólogo de adultos y cardiólogo pediatra y finalmente lo descarga. El modelo pediátrico adulto combinado o pediátrico avanzado, que es el que se hace en la mayoría de hospitales en Latinoamérica. El cardiólogo pediatra ve el chavo, ya cumple los 18 años, pero lo ve un poquito más, 20, 21, 22 años. Es ahí donde ya el cardiólogo pediatra empieza a tener problemas, porque empieza a valorar al individuo y entonces cuáles son las constantes normales, si estos laboratorios me son iguales, si los niveles de hierro los manejo igual, si lo voy a medicar con la misma beta bloqueador o no, y entonces tiene una serie de problemas donde ya el cardiólogo de adultos empieza a intervenir y si tiene conocimientos en cardiopatías congénitas pueden hacer un trabajo conjunto para finalmente encargarse del adulto congénito. Y el modelo de transición o introductorio, donde el paciente pediátrico recibe educación y finalmente es trasladado al cardiólogo del adulto. Realmente estos tres no son modelos de transición. Ahí nunca hubo educación. Simplemente el chavo creció, lo manejaron y lo pasaron. Este es el único modelo donde existe educación en la parte pediátrica y es el que debería implementarse en los centros y hospitales. Y esto lo hemos trabajado. Yo en SIAC, ustedes pueden ver varios manuscritos que hemos publicado, donde la labor del cardiólogo pediátrico y el cardiólogo especialista en adult congénito es ser un puente para que el paciente joven con defecto congénito pase al adult congénito y no sea perdido del seguimiento como se mostró en la gráfica previa. En conclusiones, las cardiopatías congénitas son una enfermedad crónica para toda la vida. La pérdida del seguimiento es un importante problema. Por lo tanto, el manejo multidisciplinario desde la infancia hasta la edad adulta es supremamente necesario y es necesario crear programas de transición en toda Latinoamérica. Así que con estos programas de transición nosotros logramos que la pérdida del seguimiento de estos individuos se reduzca sustancialmente y podamos tener que los éxitos de la cardiología pediátrica se puedan seguir en el adulto también. Muchas gracias.